If you grew up in the US like I did some 30 years ago, you'd be familiar with Sesame Street. And in Sesame Street, there was a particular scene they often pulled up, which is one of these doesn't look like the other, where they would show four children doing roughly the same activity. One of them was clearly an outlier, and that would be a description, an apt description of what I'm about to share with you. And I'm a misfit for a lot of reasons, and I'll explain that as we go. This is titled Enabling the Malcontents, and by that I won't whisper the other M word, which you guys have been talking about all day today, but we call them malcontents for a lot of reasons, and we embrace the notion that they don't think like we do, that they intend for a very different outcome, both for themselves and for society. So the most common question I get asked throughout my career, and still now, and still mostly by my parents who don't understand what it is that I do, is this, which is, what is the role of design in health? And I won't for a moment presume that you actually are familiar with design, or certainly with the practice of it in health and healthcare, so I'm going to explain that first. Let's see. Design, for most lay people, is associated with something aesthetically beautiful, either the output of someone who does interior design or fashion design. Most people understand design in that way. What they often miss, though, is that design is not just about an aesthetic output, but an approach to actually solving problems of very human nature. You can't talk about design without, unfortunately, quoting Steve Jobs, so I am, but I actually much prefer this description of design, which comes from Fast Company. It's not just an object or an end result, it's actually about a process, an action, a method to getting at very different results than you currently do. When I got asked the question, what is the role of design in health, I often answered it with the kind of work I was doing at the time I was asked. And my own history is inseparable from a company called IDEO. So you either know very much about IDEO or very little about it, and usually it's the latter, which makes it very uncomfortable at dinner parties. IDEO, if you don't know, is probably one of the most preeminent design firms in the world. I have a very sordid history with the company, having been at it 3 times over the course of the last 25 years. And IDEO got famous originally when it was first founded for actually designing a lot of very iconic Silicon Valley technology products. And so the first computer mouse, the first commercial computer mouse for Apple Computer was designed by IDEO. The first laptop computer in 1982 for a company called Grid Computing, where a screen folds over a laptop, was designed by, over a keyboard, was designed by IDEO. And then the Palm 5, which I assume most of us are old enough to remember, which is the precursor to all of our current smartphones, was also designed by IDEO. And so IDEO got quite famous for taking what were inscrutable technologies, cooked up in research labs and really the domain of engineers and scientists, and turning them into things that other humans could and wanted to use and found utility in. If you spent any time with anyone at IDEO, in the first 5 minutes, they would eventually draw this set of circles for you, which is this proper surrogate for design as a whole, which is we look for the intersections between the human needs, the technology that enables it, and the business models that sustain them. And in the middle of those 3, in that Venn diagram, is where you find real innovation. So at IDEO, I ran the business side, the healthcare side of the business. And we did a lot of work across the entire spectrum of healthcare. On the left, you see a picture of the Cleveland Clinic Abu Dhabi Hospital. We designed the facility, but more importantly, the patient and provider experience in pursuit of a very interesting care model, developing Western medicine in a Middle Eastern context. We designed and founded most of the innovation centers. This is the Center for Innovation at Mayo Clinic. We founded Kaiser Permanente's design consultancy. We did it for Hopkins and a number of other institutions as well. We worked across even the soft side of healthcare. We worked with Nike trying to help people figure out how to be more active. One, because from a corporate social responsibility standpoint, it mattered for Nike, but also because it helped them sell clothes and shoes to people who weren't couch potatoes. The fourth picture there is the archetype for what was the health insurance exchange in the US. When Obamacare launched, the states were responsible for establishing their own health insurance exchanges. The feds decided they had to do their own when more than half the states decided they would not. And we designed the archetype for the interface and the experience for that. And then finally, part of the history of IDEO's healthcare practice was the design of medical devices, and that's where my background comes from. I'm an engineer by training. So I share all that with you to say that it was tremendously fascinating work to work at IDEO for all those years, but in the end, a little bit disappointing. And I'll tell you why. The reason is we only ever got to work on the edges of the dysfunction. We were invited by our clients to work on things in their siloed approaches to evolving healthcare that would in the end make them money, but not necessarily solve the root problem in healthcare, which was manifested in a lot of interacting challenges. We rarely got the opportunity to design a new model that embraced wholesale change, and my own transition from commercial consulting to academia was bound to an opportunity that looked like this. And I have to explain that. So the origin of the Design Institute comes from a really unique set of circumstances in Austin, Texas. Austin is right in the middle of Texas. It is its state capital. It is unlike the rest of Texas. It is what we call a blueberry in a very red state. About 6 years ago, the residents of the county that contains Austin, the county is called Travis County, voted to raise their property taxes. The property taxes that were committed to health care for the poor. They voted to raise that by 63% in order to fund a few interesting things. And now that's particularly notable in Texas, one, because nobody votes to raise their taxes very often, and then because property taxes are the primary form of taxation because there is no state income tax in Texas. And they did so for a couple reasons. One was to build a new county hospital. It was 40 years old and in dire need of replacement in what is the fastest growing city in the US now, I think 8 years running. They voted to help support a medical school. $35 million annually goes to the Dell Medical School. As far as I know, that is unique amongst American medical schools, and that community dollars support so much of its mission. It is the first new medical school at a Tier 1 academic research university in 50 years in the US, and that's important for a reason I'll explain in a second. But actually, most importantly, that funding established a new local payer. So the local Travis County Healthcare District, which pays for care for the underserved, was funded in large part by this tax increase. And that payer committed to a very different model of care. It said, fee-for-service, as we know it in the US, hasn't produced the kind of results that we had all aspired to, certainly not generations later. And so it disavowed that and it said, we will pursue value-based models of care, and because we are the payer, we can invoke that change by forcing the providers to abide by the models that we develop. And the faculty of the medical school is responsible for those models. And so I was given a call by a friend of mine who was the dean of the new medical school. His name was Clay Johnston, and then the dean of the College of Fine Arts. And they said, we anticipate a set of opportunities and circumstances that allows us to build a new model for what a modern healthcare system, certainly in the US context. And we have all the usual trappings of the medical school. We have academics and researchers and clinicians and all the usuals, but we don't have someone who can help us think outside the box. And we'd like you to establish, we think designers would be the ilk that would help us do that. Would you please consider establishing a design institute at the University of Texas? And I remember putting down the phone, laughing, calling my wife and said, I had the most ridiculous proposition. And then 3 months later, we announced the Design Institute. So we are now 3.5 years old. We are a joint collaboration officially between the Dell Medical School at the University of Texas and the College of Fine Arts, which is where design is housed at University of Texas, which tells you a little bit about how prevalent design is, which is not very. I had spent 15 years in California. I was a graduate at Stanford. I understood the impact that design could have. I was the beneficiary of that individually, certainly in my career, but also understood the impact it could have at large complex systems. And this was my opportunity to actually get at the heart of the problem. So, unfortunately, I think we've lost, there we are. That funding and those circumstances gave us a lot of levers in order to affect the way we were developing new healthcare ecosystem in Travis County. I won't go through all of these, but each of these in combination with each other means that we're actually taking a very system approach to solving for the healthcare problems that we have. And it's unique, as I understand, in the US certainly, and as I've traveled the globe, more and more so, I think internationally as well. So our belief is that you can actually design for a very intentionally different outcome. From the Design Institute standpoint, we feel like there's 4 trajectories we can have immediate impact on. One is changing what is traditionally a very physician-led culture of medicine, an orientation to one that is more self-enabled. Importantly, it's not about discarding the physician. He or she has an important role in this, but we believe there's a shift in orientation that needs to happen. The experiences, in large part in the US, because of the way we're paid, are very transactional. We actually believe they need to be human-centered to return the primacy of the patient-provider relationship to the center of medicine. To shift what is a very siloed approach now in industries to one that's much more integrated, and actually one that shifts an industry focused on medical care primarily to one that's much more about the social determinants of health. When I get asked this question now, what is the role of design in health, my answer is actually quite different, and it's actually quite simple. The role of design in health now is actually to provoke change. We serve as an institutional hot poker that the Dean uses quite insistently to force our colleagues and the regional health system to think very differently about the work that they do. I'll give you a few examples, and I'll end with the one around education. Often we're asked to provoke a change in perspective. When we first arrived at the University of Texas and in Austin, we asked, how is healthcare funded and delivered in this region? And exactly 0 people had an answer to that. Everyone we asked knew a little bit of the story, the part that they were participating in, the part that funded their business, the one that guaranteed their viability as a business, but nobody really understood it as a whole. And that's a classic dysfunction of healthcare, certainly in the US. We don't understand actually our costs, how it's funded, and then how care is delivered. So the regional players said, why don't you build the map? Stop asking us. We don't know. How about you build it? And so we did. We built it. It goes online in about 2 weeks. We have a print version. It goes digital in about 2 weeks. And it captures all of the entities we believe have a role in the healthcare system. Everyone in our region who sees this stops and takes a picture of it because they've never seen it before. Anyone from a region that's not ours stops and takes a picture of it and asks us if we could do the same for them. Importantly, there's this quote that when you first launched the site says, this ecosystem of care map is a necessarily incomplete, possibly inaccurate, but urgently needed map of health delivery in Travis County. And the point is not about being right. If we wanted to get this perfectly right, we'd spend another 7 years doing it. But the more important thing is actually provoke the system to actually question what its role is and what the individual players do inside it, and actually to shame them in many ways to give us the data necessary to actually characterize the system more accurately. Sometimes we're asked to provoke a change, in this case in collaboration, about calling out the uncomfortable truths. So in the US, there is very little systemic care coordination. This is an oxymoron, mostly because care coordination ends at the front door of most organizations. When they stop getting paid to do care coordination, they stop coordinating care. Because of our purview from a financial standpoint, we have an interest in the population's health. We actually have an interest in systemic coordination across the system. So we worked with the local healthcare district and identified 9 collisions. And the collisions were between what the system, how the system behaved, and what the actual individuals wanted as an outcome or an output from the system. I'll give you one example. The data quandary, the one in green, is not actually an IT issue. So it is a competitive benefit for a healthcare system not to share its data with people outside of its domain. If they do not, then the patient is more likely to return to them for care. When the patient decides they want to go somewhere else, they are more often than not handed a huge 50-page printout of the EHR with some oral directives from the physician and expected to carry that information, interpret it, and bring it to their next physician. The quandary is this, is the receiving physician doesn't trust the data they're given and doesn't believe that the patient could have understood what the previous physician had told them, and then we end up with the data quandary. Those are the kind of systemic collisions that we're talking about. We are now working against each of these to actually create a solution to them. It will be maybe a lifetime before we're done with them, but to actually begin solving a problem means you need to identify them first. Sometimes we're asked to provoke change in clinical relationships and to shift the power dynamic. We inherited a building that was designed for a very traditional fee-for-service model. The dean disavowed it, and so did we. We designed a very different building that was designed for integrated practice units and a very intentional value-based care model. I won't bore you with the details, but I'll tell you the highlight, which was we chose to eliminate the waiting rooms. And that was a choice. And I can't tell you the fistfights, intellectual fistfights mostly, that I got into over the course of 2 years, trying to convince everyone from the EMR vendor to the architects to the clinical lead that waiting rooms were not a necessity in a modern model of care. I even found one of the clinicians actually secretly paying off facilities to build a waiting room out of one of the patient rooms. The only problem is I had paid off facilities first, so I knew about it, and we did manage to launch it. So we launched that a year ago. I'll tell you now, there's not a single clinician that complains about the lack of waiting rooms, because that wasn't really the issue. And part of our job was to provoke them into that new reality. This is the entry to our medical clinics. We separated the front and the back of house. This looks nothing like any medical clinic you've ever been to. We had the chief technology officer at the Health and Human Services Department walking and said, "This is very disorienting." And we're like, "We know." That was part of the point. Sometimes we're asked to provoke change with technology, and I know much of the conversation today has been about technology, but I'll tell you our perspective is very different about technology. Technology for technology's sake, I think, as someone said on the last panel, is not really the point. In our case, we're actually most interested in returning to that primacy of the provider-patient relationship, and so we try to get humans to interact again. So under the umbrella term of exam room of the future, we're exploring a lot of technologies. We launched just last month a joint startup with an MIT spin-out using voice recognition in the exam room to eliminate the need to type into an EHR, so that it can actually draw the intelligence from the conversation in the room, fill the EHR, and the only thing that the physician does is then has to error correct to make sure that it captured things correctly. Ideally, that returns something like, 40 minutes out of 40% of every hour back to them and back to the relationship that is in the exam room. Sometimes we're asked to provoke change in models of care. We were granted the planning grant. Well, originally, the state of Texas was going to invest $300 million in rebuilding the state insane asylum, which was their response to what does a modern mental health model look like. Our response was, rebuilding a concrete building that's 80 years old with padded walls is probably not an answer to modern mental health issues. Why don't we spend a fraction of that, and they released about $15 million, to actually, as a planning grant, so that we could actually redefine what a modern mental health model should look like. Early diagnostics and screening in relationship with schools and children and their parents. We've completed that project, and now we begin the hard task of actually convincing the legislature to fund that work, and that's what comes next. Sometimes we have to provoke change in priority. The biggest shift for us as we move into redesign of the primary care model is actually thinking about how we integrate social services with primary care. And so we spent a good part of the last 3 years trying to figure out how to engage communities in a conversation about their needs. Not by doing health screenings and having intellectual conversations about health quotients in their neighborhood, but actually engaging them and having conversations with them about what health actually means when manifested in a personal life. And they talk about social connection, they talk about neighbors, they talk about access to food and exercise and transportation. And so we recognize that actually in order to design a very different primary care model, we have to integrate it with the needs, the social needs that are resident in those neighborhoods. And we were just awarded a grant and then awarded a project to do both of those in an urban and a rural setting. And then finally, in the context of all this system change, it is, in the end, healthcare is a system of people, right? The most valuable transactions in healthcare are the interactions that happen between people, and the people who lead them are clinical providers. And the question we ask is, if we build all these systems, how will we equip them with people who are keen and able to thrive in them? And so, unsurprisingly, we have a role in educating the medical students as well. So the Dell Medical School now is on its third class of students. We only have 50 students per class for now until our accreditation comes through in subsequent iterations. Eventually, we'll probably be closer to 300 students per class. One of the coups that we pulled off was convincing the accrediting agencies that we could jam all of the book and classroom lab learning in the first 2 years into the first year, send the students through clinical rotations in the second year, and then free up the entire third year for what we call a leadership and innovation track. And so most of the students have access to either a 1-year MBA, a 1-year Master's in Public Health. Next year will come online a 1-year degree in biomedical engineering. There's a degree in value-based health coming, and we weren't around when the first students came to the medical school. And I often tell my colleagues, never underestimate the cult of personality, because they began asking, how do we spend more time with the Design Institute? And we said, well, we didn't intend on teaching. But let's ask a question. How many, if you were offered something in design, would be interested in spending that third year with us? And of the 50 students that were in the first class, 28 raised their hands. And we said, no, we can't do that many, because we're not prepared to. So we told them they'd be guinea pigs, and that they would have no degree as a function of spending time with us, and we'd reduce the number to 9. And the truth of the matter is, actually, next year they will get a degree. And so what we're doing in this next year, and we've just begun, is teaching these students design. And it's particularly notable that essentially 20% of the class would come to us, because an MBA or Master's of Public Health or any of those other degrees has a known value for a physician in the current market. Design does not. And so it's particularly courageous amongst a set of students who are already quite courageous for having come to a very new medical school, to lean in and spend essentially what is their unique component of their medical school training with a bunch of crazy designers. And so what we've done actually then is developed a curriculum over this next year, which I'll describe to you. It begins with some basics. One is what does design look like, and it includes multidisciplinary team-based work. They will do real projects in the community. If those projects are successful, they become part of the strategy of the medical school. And if you talk about flipped classrooms, that's actually a very, very flipped model where the students actually define some of the strategies of the medical school. And it's a very studio-based design practice. In the same way that you might learn architecture, we are teaching them design. The students then spend the first semester getting introduced to design and to some interesting aspects of design as it is practiced in healthcare. And then in the spring, they spend some time developing some of the core skill sets of design, but actually spending most of that time in a studio class developing a response to a community-based problem. In the middle of that, in those 3 boxes that are clear, they get an opportunity to take advantage of the broad set of curriculum that's available at a university like University of Texas, and take classes that focus them on a very specific concentration in design, which is up to them as a choice. We offered them 6 concentrations in storytelling about how you communicate individually and as a leader, 2 in the design of businesses, business models and financials, 3 in the design of service models, something that might be more akin to hospitality than it would be to healthcare, teaching them about digital interactions, because so much of what we've talked about today is about understanding how humans interface with machines. 5 about health communications, because as you change models, you have to develop campaigns that help a population understand what you're doing. And then finally about organization design, because in the end, healthcare reform is about organizational reform, and we have lived that reality now for 3 years. This first class has chosen primarily storytelling, service design, and organizational design, maybe not surprisingly. As they have come in bright and bushy-tailed and eager to change the world, they've run full bore into an existing clinical rotation, realized that the organizations that they're working in need to change in manifest ways. They are the products of poorly designed services, and they realize how poor they are at their communication, at least their peers are, and so they've leaned into that. The community projects we put into are actually quite interesting as well. And so the 5 partners we currently have, and there were many more who asked, but we couldn't take them all, actually represent a pretty broad swath of healthcare and the different opportunities about where healthcare will evolve. We're working with a local retailer to actually develop an integrated clinic, pharmacy, and food intervention that actually addresses as much about the social determinants of care as they do the medical ones. We are working with the local emergency medical technicians to expand the role of paramedics in the community. One of the local federally qualified health centers is building an adolescent clinic as an offshoot of traditional pediatrics, and trying to figure out how to engage adolescents in their own care as they make the transition for those who are from children to roughly adults. Redesigning the role of medical assistants in community clinics, and then finally writing and fulfilling prescriptions for exercise with the local YMCA. So each of these represents what we think is a vanguard for health and healthcare. We try to say health more often than we do healthcare because we believe the opportunities are outside the clinical walls. Actually, the real change in health and society will happen further and further away from the facilities as we know them now. So what comes next for us is actually measuring the career impact of a design education. We have a Fulbright scholar who's doing a multi-year study of what happens to these students once they've learned design. Next year will be an interdisciplinary expansion, so the degree, a master's of design, master's degree in fine arts, in design and healthcare, as far as we know, it is the first to be offered in the US and probably internationally. And it will draw students from 7 or 8 other schools in addition to the ones from the medical school. So I'll end with this, and I know we have questions upcoming, but I'll end with this notion, which is we've talked a lot about technology today. That technology shift is happening within the context of changing systems. But I would say that as we consider the systems and how they change, we also have to consider the people who will lead them, because changing systems actually then require changing leaders. Thank you.